Good evening, everybody. Welcome back to another webinar by Beating Hearts. Today we have Datuk Dr. Chua, who is from Sunway, to give us a talk on approach on common upper GI symptoms and problems. This is also a very suitable talk for a lot of people in the public as patients, because this is a very common condition. Wouldn't you say? Very common in a presentation, even in my cardiac clinic. So without further ado, maybe you can press the present button and then we will go ahead with this talk. Okay.
You hear me, everyone?
Yes.
Okay. Good evening. I'm Dr. Chua. I'm the gastroenterologist from Sunway Medical Center. Now, I'm just going to give a very brief and simple talk on common upper GI symptoms and problems. This is more targeted towards what you see in the general practice, because I do understand that your resources can be a bit limited in general practice, and the whole armamentarium of drugs sometimes may be a bit limited as well. So what happens is I'm going to go and briefly tell you about upper GI complaints. They're very, very common. The main complaints you will see are complaints like dyspepsia, heartburn, bloating, epigastric fullness, abdominal pain, something in the throat, choking, shortness of breath. These are all very, very common. In terms of heartburn, some of which may or may not be good. They are defined as 40% of people have it about once a year, about 20% of the Malaysian population have it every week, and approximately 5% almost daily. And these figures are taken from a survey done by University Malaya a couple of years ago. I think it was 2012 or 13.
Sure. Is it more common in as you age?
There is no real what we call distribution.
Mm-hmm.
It is present throughout all ages or age groups.
And the pain, even in something in the throat, is very, very because
disturbing.
Yes, and it's very similar to what we have where it's a radiating pain from the cardiac angina. And I myself have experienced this something choking in the throat, and I've got myself investigated for actually angina. Eventually, it turned out to be, yeah, good.
Okay, I will elaborate a little bit more on the throat, something in the throat, because that actually is actually very common, and a lot of people sometimes misclassify it as actually GERD when it's actually not or cardiac angina.
I see. Okay.
So this upper GI complaints, if you look at GP surveys, they account for between about 15% to almost up to 1/3 of GP visits. Okay. Well, these are European figures, these are not Malaysian figures. So I'm going to give you a brief overview of which patients in the GP practice, when you see, you should refer straight away, who you can treat and what do you treat for, and the differential diagnosis to consider when you have upper GI complaints. So usually it's things like esophagitis or reflux with or without esophagitis, functional dyspepsia. I will go into this a little bit more. Gastritis or ulcer type syndromes, and the other thing which you call lump in the throat is globus, essentially. I also touch a bit on motility disorders and gallbladder and liver problems, which you have to consider. Okay, so it's a bit of a mix of everything. Now, just straight up, who you should refer straight away if you get this kind of patients, which you don't even want to try to manage or investigate. Immediately, if you have things like dysphagia, profound weight loss, if you've got bleeding symptoms like melena or hematemesis, any profound anemia, a patient who is not known to be anemic like thalassemia or any other hemoglobinopathies. If you can feel something like a mass during examination or something that alarms you during examination, these are the kind of patients you don't want to really be managing there. You want to refer them straight away. Now, there is another group that's a little bit more subjective. There's a group of patients who are very, very anxious, and these are the patients that sometimes you may not want to hang on. You want to refer them straight away. If nocturnal pain is really prominent, they tell you that I have a lot of pain at night when I go to sleep, into the back at night. That usually is something a bit more sinister. And if you have that, I would advise you to refer it straight on if the patient is keen. Now, if the symptoms are very chronic, if they've been lasting for like 6 months to a year and it's not getting better despite treatment, or dinophagia, which means painful swallowing, this is also a bit relative. I mean, some patients will want to be referred, some don't mind being seen in GP. And patients with all these symptoms, new onset and above the age of 50, they've never had any gastric symptoms before. They've never had any upper GI symptoms. They come in above 50 with any one of the above. You would want to exclude something a bit more sinister and refer these patients. Okay. So with that out of the way, what I would say is my approach in the GP practice would be mainly symptomatic. So there'll be the three things I'll cover is globus, GERD, and functional dyspepsia, which I will try to divide into an epigastric syndrome kind or postprandial distress syndrome. And I'll talk a bit about the role of H. pylori testing. Okay. So like Betty mentioned earlier, globus is actually very common. Now, it's a sensation of something in the throat and is usually above the sternal notch and the cricoid cartilage. So if you look, it's usually in the throat in between where the cricoid cartilage is and the sternal notch. The patients will always say that there is something there when they are not doing anything, when they are not swallowing, when they are not eating. And usually they will say that, oh, when I'm very free, nothing to think about, I will feel that. The key thing with this versus dysphagia is that it is relieved by swallowing fluids or solids. So you have to ask the question, is when you eat something, does it get stuck or does it get better? Globus, typically they tell you, no, when I eat something, it goes down very smoothly. I don't feel anything at all. When I drink, there's nothing, there's no regurgitation. I don't cough, it goes down nicely. So typically it is in the younger population. I will be a bit careful if it is older smoker because sometimes you get cancer of the piriform fossa or base of tongue. That's the thing you need to watch out for when you get these symptoms. So typically they're like 20, 30 or 40 years old and you see a lot of them during this MCO because of increased stress level. The thing with globus is that there's usually no organic cause found. There's multiple theories. They say it's from reflux, pharyngeal inflammation, postnasal drip, hypersensitivity. Some of it may be psychiatric as well. So this kind of patients actually quite typical. Normally you look at them, they are a little bit anxious. They have some flight of speech. They are usually very young and there's no alarm symptoms. Okay. These patients, you don't actually need to investigate because the history is actually quite typical. So normally it's the guidelines that you give for GERD patients. You don't smoke, avoid vaping and alcohol. Now, in terms of treatment, you can treat with PPIs. Now, any PPI is fine, but the key thing is that you should do BD dosing. And if the patient has any amount of heartburn or dyspepsia, you will find that the PPIs work quite well. You should also look for H. pylori. Now, in terms of H. pylori testing, for most of these patients, if they don't want to do a breath test, just do a serology, and that should be enough. If they have any symptoms of postnasal drip, try some antihistamines. Anyone is fine. I mean, Zizal, cetirizine. And if all those are tried and they don't respond, tricyclics can be quite useful. And the other thing which I sometimes use before I give tricyclics is baclofen in combination with any of the above. Now, generally, you would treat for about 2 weeks and they should see some improvement. If there is improvement, I would continue the treatment all the way up to 6 weeks. The key thing is that there is only about 50 to 60% response to treatment. You'll find that about 1 to about half of them do not respond. And if they do not respond within 2 weeks of treatment, just refer them on. And usually you'll find that there is a high correlation with stress. Now, what I normally do is when I get these patients, I would, at the very minimum, do a barium swallow just to make sure there's no disorder, plus minus endoscopy for H. pylori testing and to make sure there's no stricture. But I can tell you invariably, I get a lot of these patients, maybe about 3 to 4 a week. 99% of them, the scope is normal. And the barium shows maybe some reflux or sometimes some tertiary contractions. I've not had anything like achalasia or nutcracker esophagus with all these patients. Any questions so far on this?
I want to ask, what is tricyclic?
Tricyclics will be things like your amitriptyline, basically.
Oh, I see.
I normally use amitriptyline, but don't go on really high doses. Normally you go on 10 and step it up if you need to over a period of about 2 to 3 weeks.
Okay.
Don't start at 25 because 25 usually is not well tolerated in our Asian population, I find. Now, the other thing which I'm going to talk about is GERD. GERD, I don't think I need to talk too much about it because it's very common. But you have to be a little bit careful because what is GERD is very specific to the gastroenterologist. It does not include things like bloating. It does not include things like burning sensation in the tummy. It does not include things like diarrhea after meals. What typical symptoms of GERD are is that you have heartburn, you have chest pain, you feel the regurgitation after food, and it is worse on lying down. This is typical of GERD. It can sometimes be triggered by exertion. Let's say you had a heavy meal and then you go out for a run, you'll feel burning sensation in the chest. And these patients some end up with a cardiologist and they get investigated, there's nothing. And I get referred these patients. Now, there is sometimes some overlap with other symptoms such as bloating, dyspepsia, but when you want to diagnose GERD, you have to be sure that most of the symptoms are the typical symptoms. Okay, if you have a lot of other weird symptoms like I've got giddiness, I've got headache with it, some patients say I got hearing difficulty, I got poor appetite, I got poor sleep, then it's probably not pure GERD. It's probably one of the functional disorders plus minus GERD. So again, with GERD, if you're on the GP practice, I'm very sure you see it quite often. My suggestion is just treat it with PPIs. Again, I don't advocate daily dosing unless you're using something like Dexilin, which is controlled release. I normally give DD dosing for 2 weeks, bring back review and step it down if it's working. Now, it is very, very useful to do H. pylori testing in these patients. Serology is very cheap, but it is less sensitive, but better than nothing. UBT is the gold standard. If I'm not mistaken, serology is about $60 and UBT is probably about $300 outside. So there is a significant difference in price. If they've never been treated, serology for me is good enough. The sensitivity we're looking at with serology is about 60 to 70%. And with UBT, you're talking about 95 to 98%, depending on whether they have an antibiotics or whether they have no treatment. So if you plan to do the H. pylori treatment, H. pylori testing, you should do it before you start treatment. If you have started treatment, then the urine breath test is not very useful, just kind of serology. Now, typically, if it is classic, they tend to respond very well. But what you may see is that you may get a breakthrough when the treatment is tapered down. Now, if it is just pure GERD without any of the bloating, any of the functional symptoms, I usually find no role for prokinetics. I find Ganaton or Meltilium adding on to it doesn't really help symptoms very much. Now, I don't have any particular PPI preference, but if using delayed release, I use Dexilin, where you just have daily dosing, which is a lot easier. There is talk about giving PPI in the morning and then giving histamine blockers at night, because that is more in keeping with your what you call body's rhythm of secretion of acid. But I find it's not really superior. I don't find giving PPIs in the morning and at night giving a histamine blocker like ranitidine or famotidine really much benefit. Now, if you treat after 2 weeks and the nocturnal symptoms are a problem, usually I would consider something new called vonoprazan. Now, I'll talk a little bit about vonoprazan or Vocinity because I think it's fairly new. It's only been in the market for about 2.5 to 3 years, and not many people have much experience using it so far, I find. So basically for these patients, when would I refer? Basically, if after 2 weeks of treatment, you don't get any relief whatsoever, I would send it off. If after 4 weeks of tapering, you get a relapse, you should also just send it off for further investigation. And typical alarm signs are set out earlier, and as I mentioned earlier, anxious patients. Normally what happens when these patients come to me is that at the very minimum, they get an upper endoscopy, and after that, they do institute some treatment. Sometimes if they don't respond, I will do a brief study of manometry just to make sure I'm not missing an esophageal dysmotility disorder, or if actually it's in fact actually GERD or something else. Okay, now I'm not sure how many of you are familiar with vonoprazan or what we call Vocinity. Now it is fairly new, like I mentioned earlier. It's about three years in the market, though it's been in Japan for a bit longer than that. I think since 2015 or 16. Now, it's what we call a potassium channel blocker versus your PPI. So that's a little bit different, and I'll elaborate a little bit about it. Now, the trade name is called Vocinity. And I find this new molecule actually quite interesting because it's got a big role in my practice, especially in H. pylori treatment. I find it very useful in patients with nocturnal symptoms. And I find that the effect of this is a lot faster than a PPI. But by the same token, because it's so powerful, I try not to use it unless it falls into those certain circumstances which I've just alluded to. Now, if you look at what we call a typical PPI, what happens is I'm just giving you a slide of lansoprazole. Lansoprazole is Prevacid. Basically, what happens is that it needs to be converted to an form by an acid, and it works onto the proton pump to prevent the gastric acid from being secreted. Okay, so it has to be taken on an empty stomach. It should not be taken after meals because you reduce the efficacy of it. So normally, if you give a patient a PPI like an Nexium or something like Controlog, you would advise them to take it ideally about half an hour to an hour before your meals. Because taking after the meals, the effect's a bit less. But you should tell the patient that if they forget, doesn't mean you cannot take it after the meals. You can and you should, rather than not taking it. So we got to get it correct. It doesn't mean that after the meals, you take it, there's no effect. It's just less effective. Now, the difference with Vosinti is that this is a potassium channel blocker. It doesn't require any acid activation. So the key thing with this is that you can take it anytime. You can take it before, during, or after your meals. It doesn't really matter. So it's a lot easier in terms of compliance because you don't actually need to wait before the meals, because some people would take meals irregularly, they forget. That's the number one problem my patients tell me. Oh, I forgot I have to take this 1 hour before the meal. Then I took my meal and I thought it's too late, so I stopped taking it. Okay. So if you look at the pharmacokinetics of it, the difference between the PPI and the PCBs or potassium channel blockers are that the duration of action is very fast. From the first dose, very rapidly you get acid secretion, acid suppression, okay, or the pH goes up. Whereas if you look at this chart, what happens is that if you take the PPI, it does take a few days to build up the effect. So you very often have patients that tell you that I take Nexium only on the 3rd or 4th day, I see some improvement. Now, normally with something like Vosinti, they'll tell you, oh, within 24 to 48 hours, I feel better already. Okay. So this is the main difference, but the other main difference is that it is a lot more potent. Now, this is very, very important when it comes to H. pylori monitoring. I'll talk to you a little bit about this. So when they did a 24-hour pH monitoring, if you look at vonoprazan 20, don't look at 20 and 10 now, because I don't think that's really that accurate. You look at 20 and 20, which is an equivalent dose. Rabeprazole is period. You will see that the pH goes above 7 for quite a bit of the time when you are on Vosinti, whereas it hardly ever reaches that when you're on Rabeprazole. So this has two important implications. One is in H. pylori eradication, which I'll talk to you a bit later, and the other one is relief of symptoms if you're actually having that. Now, in terms of H. pylori treatment, very quickly, I'll tie it up with this. There are multiple regimens, but we have issues with resistance in Malaysia, and I'll also talk a bit about the importance of pH. Okay. Now, these are the Malaysian guidelines with that came out in 2019. These are from our own Malaysian guidelines, where they talk about the first line, second line, and third line. Now, I'm sure most of you are familiar with the normal HP 14. Now, please note that it's no longer 7 days of treatment. The guidelines have all changed to 14 days of H. pylori treatment, for the simple reason that for 7 days, there is a lot of antibiotic resistance now. And what happens is that there is a lot of treatment failure. Now, very quickly, if you give 1 week of HP7, the current data shows that you only have about 60% eradication rate. If you give it for 2 weeks, it is up to 81%. Now, HP7 is a combination of Controlog, pantoprazole. You can use generics, no problem, amoxil, and clarithromycin. Okay. Now, the two problems with the treatment regimens, as I mentioned above, is resistance and pH suppression. Now, if you look at this HUKM data, this is 2019, where they looked at H. pylori resistance. They had 288 samples, 59 were culture positive. Now, the 59 culture positive, more than half were resistant to flagyl, about 1/3 to erythromycin, and to levofloxacin, about 1/4. Now, single, dual, and triple resistance are 43, 16.2, and 13.5. 73% had at least one antibiotic resistant strain. So normally when they do the panel, they'll do for doxycycline, they'll do for rifampicin, they'll do for metronidazole, classic levofloxacin. Now, the key thing is that no resistance has ever been detected to tetracyclines and amoxicillin. Okay, but you may get resistance to the rest. So that is one problem with the regimen. Okay. The second problem with the regimen is that if you look at this chart here, this tells you about how H. pylori proliferates in the stomach and what pH. So H. pylori, when they are proliferating or when they are dividing, they are most sensitive to the antibiotics. Their proliferation is highly dependent upon the level of pH. Now, if the stomach is really acidic, you have very little proliferation. When your pH goes above 6.5 to 7, that is when it is proliferating the most, and it is when it is most sensitive to antibiotics. So when you use Vosinti is where the red circle is, you suppress the pH to between 6.5 to just a little bit above 7. And that's the point where most of the H. pylori proliferates. So if you actually treat it at this level, you would expect better success rates. Now, if you use the OPPIs like Nexium, Controlog period, it's normally between 5.5 to 6.5. So that, I would say, accounts for the slightly better superiority. Now, I know it's not in the guidelines. It's not in the new guidelines because the guidelines were formulated in 2019. And this is probably based on the data in 2016, 2017, 2018. And we have only had this medication for the last 3 years, since early 2019. So when they formulated these guidelines, I don't think this was actually available yet, or they did not consider this data. So basically, if you look at the H. pylori eradication on Nexium or omeprazole, you can kind of ignore this slide, but basically it shows that you have a 70 to 80%, and this is Japanese data. So what they did was they compared eradication rates between the standard of treatment then, which was the lansoprazole base plus Vosinti, and it's a 3-drug combination. So they found that the eradication rate was actually higher and the p-value was actually significant. This was a relatively small study. Okay. So what the current practice is, most GP practices and in some of my colleagues now, is that they usually give a PPI, amoxil, and acid. There's no allergies for 2 weeks. And they repeat the urine breath test in 6 to 8 weeks. The problem is that if you have a failure, you have two chances. You have 2 choices now. Either do endoscopy, repeat the cultures, let me send for H. pylori culture, knowing that it's only about 30 to 40% yield. That's one. Number 2 is you can start the same regimen without doing any sensitivity, because even if you are actually resistant towards clarithromycin, the amoxil sometimes and the Vosinti is actually enough to give you eradication. Or you can switch it to levofloxacin or give quadruple therapy as third line, where you give PPI, bismuth, tetracycline, and flagyl. There is some small studies that show that if you combine it with some probiotics, you lessen the side effects and you increase the success rates. But this have not been proven out in larger studies now. But for me, in my practice, I would suggest that you move towards the potassium channel blockers as first line, because one, there's no resistance to the PCB. If you note that the current treatment regimens for 2 weeks, if you move to the PCB, I find that often with 1 week to 10 days, it is actually enough to eradication. So even though it's a bit more expensive, but because you have shortened your treatment duration by 1 week, it works out to be about the same. You get a bit less side effects because when you take amoxil and classic for 2 weeks, patients often complain, I got a bitter feeling in my mouth, I feel nauseated, I feel vomiting. You may get diarrhea. Actually, these are all quite common, or you get giddiness. So on the balance, I would say treating for about 1 week versus the 2 weeks and getting about the same results, the money you save is actually worth it and the time you save. I think it's also better tolerated. Now, these are not in the guidelines. Let me stress, this is just my personal practice nowadays. Now, we'll talk a little bit about functional dyspepsia as well. I find functional dyspepsia, you have to actually define what you are actually dealing with in functional dyspepsia. Functional dyspepsia is a very, very broad term, but I normally divide into two broad categories, like whether you are predominantly having an epigastric pain syndrome or whether you're having postprandial dyspepsia syndrome. Talk about it a little bit later. But basically in functional dyspepsia, you don't really get much of the symptoms of heartburn. You don't have the reflux, you don't have the regurgitation, you don't have the chest pain. They normally complain of epigastric pain, NGR. There is a feeling at the xiphy sternum. You can get some gastric burning, you complain of satiety, and it can be bad enough that you can't actually finish your meal. And you're halfway through the meal and you say, I'm so full, I can't finish it. And the common ones are prandial fullness and bloating, that after your meals, you get a lot of bloating, you get a lot of wind. Okay. Now, I find the mechanisms of it are actually not fully understood. They believe it's a combination of things like his visceral hypersensitivity, your stomach's a bit too sensitive. You can explain that to the patients. You have gastric dysmotility where you have delayed emptying, that may actually account for the satiety. May have impaired accommodation, abnormal intestinal motility, but very often it's a combination of all these factors which I've elucidated or listed here. And some of it may even be psychological. It may be a manifestation or somatization of something like a panic disorder or anxiety disorder. And that is fairly common. And I'm pretty sure in general practice, in some of these patients, when you're given things like Xanax, when you're given things like Lexapro, they actually improve tremendously. Okay. So this is just a small little picture that illustrates where the problems may be. Maybe having fundic relaxation, which is inappropriate. You may have some what we call delayed emptying. You may have what we call peristaltic movements, which are against the flow. So you actually rather get relaxation of your pylorus, you get contraction of the pylorus. So you get your stomach pushing your contents against the pylorus, and that gives you the feeling of distension and bloating. Now, I mean, all this is all beyond the scope of this talk, but just to give you an idea of what the underlying mechanisms are. Okay. So basically, like I said, clinically, it is more important to decide what you are treating and how you're going to treat. So I tend to divide these patients into two categories. One is the epigastric pain syndrome, and the other is the postprandial dyspepsia syndrome. And the treatment is slightly different. Sometimes it can be a mix of the two, and sometimes you can even get GERD mixed with all these symptoms. Okay. GERD mixed with all these symptoms, probably only about 10-15%. Mix of the two, again, another 15-20%. Epigastric syndrome and postprandial dyspepsia syndrome will account for 2/3 of your presentation in functional dyspepsia. So what do I mean by postprandial dyspepsia syndrome? It is the early satiety that prevents finishing meals sometimes, at least twice a week. Okay. Now, you get a lot of postprandial fullness or bloating after meals. It's defined a few times a week. It's probably defined, but I would say 2 to 3 times now. Very typically, this is the patients will tell you that when I have a big belch, it becomes a bit better. Or if I induce vomiting, it becomes a little bit better. Okay. Now, the postprandial dyspepsia syndrome can coexist with epigastric pain syndrome. Okay. There is a bit of overlap. Epigastric pain syndrome is how I describe it as intermittent burning in epigastrium, upper abdomen, at least once a week. You find that no other abdominal regions are affected. It is not relieved by going to the toilet or passing flatulence. Okay. Just make sure that you are not dealing with something like biliary colic. Okay. And it can also coexist with PDS and can occur during fasting, but more commonly it's triggered by meals. So the meal itself, doesn't really tell you whether it is epigastric pain syndrome or not, because it can occur before or after meals. Usually they describe it as, I feel burning, I feel heaty feeling in my stomach. It's not colicky, it's not cramping, it's there all the time. It lasts for 1 to 2 hours. Sometimes it goes away by itself. Sometimes it doesn't. So the treatment approaches, there are few. Now, I mean, in my practice, when they come to me, usually they end up with endoscopy and more targeted treatment. And if these patients want that, yeah, feel free to refer them. But what you should do is you should evaluate for H. pylori and treat if needed. Like I mentioned earlier regarding GERD, you can use a urine breath test or serology. But the problem with urea breath tests and what we call serology in patients is that even if you treat all this H. pylori, there is actually a very poor correlation with symptoms. You may treat it and you may not get any improvement whatsoever, and that can be quite frustrating. The other one which I would suggest for GP practice is that you give empirical therapy, and if possible, get an ultrasound because it's quite useful to rule out gallstones, pancreatic issues, and liver disorders. So what empirical therapy would I give? I mean, again, you have a number of choices. You have things like your PPI, you have your PCBs, and your H2 blockers. Now, how do I choose it actually? Pretty simple. I mean, I get a sense of what the patient schedule is, what their job is, what they do. Can they take the meals regularly? Are they a housewife? Are they on the run all the time? Because if they find it difficult to have regular meals, then normally I will give something like dexedrine, which is not related to meals. You can pop it anytime. Okay. Now, there are some patients who will come to you and they worry about long-term side effects. They read somewhere that taking PPIs cause bone problems, causes kidney problems. So for these patients, I normally give them histamine blockers just to allay their concerns, but their concerns are not particularly very valid actually if you look at the data. Now, the other thing is if patients have difficulty swallowing, because some patients will come to you and say that I don't want anything which is solid, I don't want to take any pills, I can only want to take syrup like Gaviscon and all that, then I give something like Nexium Meprazole because I can dissolve it in water and they can just drink it. Okay. Now, if they're on multiple drugs, if they come to you and they're already on things like Plavix and a lot of cardiac medications, you worry about interactions, give something like Controlog. If I don't have any of these concerns whatsoever, basically it's just whatever, anything, you can give anything basically. All right. So that's basically how I would choose. So in terms of empirical therapy, I usually, the mainstay of empirical therapy would be the acid blockers, basically, which one you want to choose. Now, in terms of prokinetics, you will find it not very useful in patients with gastric pain syndrome. Sorry, not very useful, yeah, correct. In patients with epigastric pain syndrome, it may or may not be useful in patients with postprandial dyspepsia. So you do actually have to define what the symptoms are like. If they tell you they have a mix of both, then you can try. If you don't even bother because you'll find that it doesn't really work. Now, in practice, I don't really find much difference between mortalium and Ganaton or domperidone and etopride, which is the most common ones used. The only thing you have to be aware of is that I find more often than not, mortalium can cause palpitations, especially in patients who are a bit anxious and patients who are on a lot of other cardiac medications, which can potentially prolong their QT interval. Okay. Now, there's another one which people use sometimes called mucosa. Basically, it's a lining onto your stomach. And I find it's only useful in patients with epigastric pain syndromes, not useful in people with a lot of bloating, with a lot of postprandial symptoms. Now, in terms of other medications, like I alluded to earlier, that some patients may actually be a bit anxious, I give tricyclic antidepressants or SSRIs. Now, typically, I prefer amitriptyline because there's a lot more evidence for amitriptyline. But you have to warn the patient that amitriptyline, in some people who are very susceptible, causes extreme sleepiness. Okay? They may be sleepy for the next whole day. That's why I normally start at 10. And sometimes some patients may say, oh, why are you giving me an antidepressant? Because I'm not, they'll tell you I'm not depressed, I'm not anxious, I don't have any psychiatric problems. So actually, really my answer would be that I give them because it's a neuromodulator. So people with functional dyspepsia, it may be helpful. independent of depression. Okay. Now, some people like to use Lexapro. I've used Lexapro as well. Lexapro is escitalopram. The problem with escitalopram is that it can cause paradoxical excitation. So in a small percentage of people, when you take it, they get palpitations, they get more anxious. Now, really, all these TCAs and SSRIs, I would tend to use only in patients who are more anxious, basically, and not as a first line, usually as a second or third line. Now, there's a few others like valdoxan and remeron. Remeron is mirtazapine. Valdoxan is also another SNRI, sorry. And the thing with valdoxan is it doesn't really cause a lot of this paradoxical excitation, but I don't find it very, very powerful. And remeron is useful if the patient has a lot of sleeping difficulties because it causes profound sedation. Okay, these are the drugs you can use, but typically I wouldn't move past Lexapro and amitriptyline for most patients. Okay. So just a very brief summary before I answer some questions. You basically just need to know when to refer these cases. Most of these cases you can treat in general practice without any investigations, except for the basic H. pylori and maybe a full blood count. Your treatment or how you target it is according to the constellation of symptoms, because you don't have much investigative modalities at your hands. You don't have a CT scan, you can't easily get an ultrasound all the time. So first, according to what symptoms you have, and basically be familiar with your PPIs, your histamine blockers, the side effects, and what to choose, basically. And the last key thing is the H. pylori treatment. Rather than using something like HP14, it may be worth considering bosentan with whatever you normally give. Okay. Thank you.
Thank you very much. Okay, we have a few questions already. Okay, do you mind if you stop the share so that I can actually share, so that I can actually share this.
I see the questions, okay. Slowly. Okay, audio is good. No, okay, the first question is if H. pylori is serologically positive on routine screening. I think the first question to ask the patient is, have they been treated for H. pylori in the last 1 year? Okay. If they have, sometimes it may actually remain a little bit elevated. So the history is actually important. Now, if it is positive on routine screening and the patient does not have any symptoms, I would suggest you start treatment first rather than refer to the gastro. Does that answer your question?
Okay. Let me see. I'm sorry. So basically, you have answered Dr. Savindan's question, right?
Yes.
Okay. And how about Natia has asked, can the stress be the primary cause or just exacerbating factor to
I would assume this was to globus. Is that the question?
Possible. Yeah, I think it is to globus.
Well, stress can sometimes be the primary cause, to be very honest. Because very often when you take a bit more history from the patient, they will often tell you when they are very busy, when they think about it, they don't notice the globus at all. This is actually quite characteristic of stress-induced globus. When certainly, yes, it can just be the exacerbating factor. Now, how H. pylori enter our body? H. pylori is serology titer of 1.1 advisable to treat. H. pylori is oral fecal. So usually it comes from contaminated water. Let's say, like, for example, if you've taken some vegetables, salads, which have been contaminated with water which contains H. pylori, it comes from parents. Let's say, like, for example, when your parents have H. pylori, they're feeding the children. Sometimes they chew on their food, they feed it to the babies, especially when they are young. So you may have H. pylori for a very, very long time. Okay, but the basic transmission route is oral fecal. So things like bodily fluids, things like saliva. Okay, but having said that, it is not in high titers in saliva. It's not highly infectious from saliva. Okay. Now, H. pylori serology of titer of 1.1 advisable to treat. I'm not familiar with your lab off actually, but again, like I said, you have to go back to the history. Have they been treated within the last 1 year? If they have been treated within the last 1 year, and if this is just slightly above the titer, it may not be accurate. You may actually still have to do a urograph test.
Okay. I'm sorry, the QR code seems to have been having a problem. Let me stop share and try to share again. Okay, let me see what's going on. Sorry. I don't know what. Let me just try again. Okay, good. Share. Hope this is better. Let's see. I've moved it up. I hope, yeah, this is better, yeah? Okay. Okay, can scan. Dr. Chua, there's a question by Ashwin Yo, who just wants to know, are there any hepatitis A, B, and C treatment? It's not related, but yeah, we can answer that question.
No issues. Hepatitis A, no, there's no specific treatment for hepatitis A besides immunization. Okay, there is a combined vaccine Hep A and B, which you can take. Otherwise, it is just supportive. We give IV fluids. We make sure that if the hepatitis is severe, we support. Make sure the patient doesn't go into hypoglycemia or go into liver failure. It's actually quite uncommon, hepatitis A, to get fulminant or very severe hepatitis A. Now, for hepatitis B, again, the vaccination is pretty important. But if you get hepatitis B, there are a variety of treatments available. Unfortunately, the cure rates, where you actually define cure as you become immune to hepatitis B, you don't have it anymore in your system, it's not dormant, it's actually pretty low. You're talking about 5 to 15%. So treatment is through medication, which there are a few on the market, things like Tenvir and Anticavir. And you have another one, which is an injectable called interferon, which you give once a week, okay, for a year. Now, for hepatitis C, it is something in progress. Now, hepatitis C used to be very difficult to treat, but now it is very, very simple. There are combination medications which you can give to cure hepatitis C, and they are available orally, which you take once a day, and the treatment duration is pretty short, and you have about 95 to 98% cure rates for hepatitis C. That even if you fail one regimen, you can go to the second regimen. Now, a lot of hepatitis C treatments done by Selayang, because the medications they use are generics and it's free. In the private side, we don't really have access to that. We end up with the what we call originals, and it costs more than 200K for a course of treatment.
Wow.
If you buy the generics, it's about 4,000 plus. They are Indian manufactured and they are just as good. There's really no difference.
Why can't we get access to that? It's really unfair.
It's not registered.
I see. Okay, we have some question from Facebook. Okay, Charlene Lim asked, what is your thought on long-term antacid like Gaviscon if the patient is reluctant for more invasive investigations, or let's say they have this fixated idea that you know, PPI can cause kidney failure?
Sorry, your question again, I couldn't catch it.
So Charlene asked, what's your thought on long-term use of antacids? Okay, if patients are reluctant to have more investigations.
Okay, I would say it really depends on the clinical scenario in which you are coming from. I mean, if you are a young 20 or 30-year-old who has been having indigestion, or they call it, for a couple of months, and there's no alarm symptoms, and you take antacids on and off and it works, then you are relatively low risk. But if you're in your 50s or 60s and it's the first time you're having this problem and you're worried about the side effects and you take antacids long term, I think you're putting yourself at significant risk of missing something else.
True.
Now, in terms of the side effects of what we call, there's been a lot of papers regarding the side effects of PPIs, and I have to explain very often to my patients. Basically, when we give a PPI, we have to weigh the risks and the benefits. Now, in this case, if you are 50, 60, you don't investigate, it is a bit dangerous. I would say medically, you can't defend yourself even if something goes wrong.
True.
Now, if you investigate and you find that there is a significant gastritis, there's significant symptoms, then you have to ask yourself, are these actually interrupting the patient's life? Is the patient able to take food? Is he tolerating orally? Is he losing a lot of weight? If there is a significant effect on your life, then I would say that for symptomatic relief, the PPIs are actually quite safe. Okay, there is not that high increase in what we call pneumonia, osteoporosis, or things like renal failure. And the key thing is they're all reversible.
Is it,
so actually, if
is
you stop
it
it,
one
it's
of the
reversible.
side effects?
And in fact,
Sorry, you were lagging. So is pneumonia, kidney failure really one of the documented side effects?
well, I mean, this was based on the ICU study. So what they did was they found that patients who took PPIs intermittently had a slightly higher rate of pneumonia.
I see. Okay.
Whereas patients on long-term didn't quite have that. And in terms of the kidney failure and all that, the large community-based studies only showed that these patients had a propensity towards ending up needing dialysis. But this study was not adjusted for population group and comorbids. So it may be that the patients who are on PPIs were patients who would probably have ended up with renal failure anyway. So it's hard to say.
Oh, I'm very surprised that there is also patients who are reluctant to take short-term medications such as PPI. I mean, I can understand when they have doubt about, statin long-term because they would have to take it lifelong. Yeah. So, hey, where are you? Are you still here?
Yeah, I'm still here.
Okay, sorry. Okay, we have another question from Laili Hassan on Facebook, and she asked, do you routinely repeat UBT after the H. pylori eradication treatment, I guess?
Yes, I actually do because of high failure rates these days. Even with, I find even with Bosentan, even if you give it for 2 weeks, with some patients I do, if they have failed primary eradication, even then you only get about a 90% success rate. You don't get 100%.
And what do you do then after if it's still positive?
Okay. Discuss with the patient. I mean, one thing to do is to do an endoscopy, culture it, take some biopsies and try to culture it and find what the resistance pattern is. That should be the way to go. But some patients are reluctant to do that. So you would treat with what we call your second line treatment.
Okay.
And sometimes I'll add on a probiotic.
Okay, so somebody asked any role of probiotic, and I think you just answered the question, but is there any role of probiotics? I see it being used quite often when my patients come with, this whole mess of medication that they have. And what is actually probiotics? How does it work, and what do we usually use it for?
I mean, the whole concept of probiotics is to actually restore your beneficial gut flora.
I see.
So it reduce your symptoms. But the problem is that there are so many brands of probiotics out there. There's so many different cultures, so many different combinations. And that what I can only say is that the effects can be unpredictable. Okay. I mean, my worst case scenario has been a patient who has taken probiotics and ended up with diffuse diarrhea and acute renal failure. We even had that.
Oh my God.
With no trigger. The only thing they took was just probiotics.
These probiotics, is it evidence-based, the use of it?
Well, no, not really. That's the problem. The evidence is all very tenuous. They're all very small studies. Okay. There is some evidence in antibiotic-associated diarrhea and AGE, but in terms of functional dyspepsia, studies are all over the place.
Sivanan has another question. Any explanation of patients who come in? Okay, with angin, I see. Okay. And when pressed on certain parts of the day, they burp. Oh.
Okay. This is actually not uncommon,
Oh, I see.
So sometimes what happens is that when you're talking about certain parts of the body, are you talking about the abdomen, or are you talking about, like, for example, if they press your head or they press your leg? I need that a bit clarified. Because if it's abdominal, sometimes it's just, you know,
Sorry,
some
you're lagging.
Sorry.
Sorry.
Or gastroesophageal junction, just some incompetence of my
Sorry.
internet connection is not so stable. Can you hear me?
Yeah, that's right.
Hello?
Now we can
Can you
hear
hear
you.
me
Yeah.
Okay. Sometimes if you press on the abdomen and you put pressure on the abdomen, it can be just some incompetence of the gastroesophageal junction. And sometimes it's just part of functional dyspepsia. But if they start pressing parts of, like for example, your hand, your leg, they start burping, it's almost certainly psychogenic. And there is a significant proportion of patients who sometimes when they are actually anxious, if you actually observe them outside the clinics, which I've seen, they are perfectly fine. The moment they come to your clinic, they get excessive burping. I'm sure you've seen that, but
Yes, I have a very I have this U factor, when people burp, I can't even see the word burp without, feeling a bit U. So, and I find it really disturbing, especially when people, when I go for a massage and then they will, massage me and the masseuse will actually burp. I think the burping, it can be put on, they are able to do it on demand, I feel. And I see it quite often where their patients will hyperventilate when you're in the clinic, and when you're talking to their children outside the clinic, it looks fine. Yeah, you're right.
The hyperventilation itself causes what we call aerophagia. So you actually swallow some air. So that air has to go somewhere. So it either goes to the bottom or it comes out from the top. That's when the burping happens. Or the belching. Now I saw the diabetic, is it?
I don't see a diabetic. Oh, yeah, that's one.
Yes.
A diabetic patient to take PPI for 5 years. Is that advisable?
Well, I would say, have you considered a histamine blocker? Because a histamine blocker is almost as effective. It doesn't have the side effect profile of PPI. It's not correlated with any renal failure. It's even safe throughout your pregnancy. So it's something to consider. That's one. Number two, that's the alternative I'm talking about. Number two is that if you only get relief from the PPI 5 years or more, are you on anything else like aspirin or anything else like Plavix or any other thing that can cause a gastric upset? Okay, that's the thing you have to ask. And is your renal function normal? Now, if you are taking the lowest possible dose of PPI and you are on regular follow-up, I would think it is quite safe.
Okay, let me just do this first because Dr. Chua has, your what was lagging. Let me just tell them first. First, you need to scan only, you can only scan if you're watching on your laptop, okay, or your desktop and use your phone to scan. You can't scan if, let's say, you are using your phone to watch. For those who can't scan, okay, please send your name, MMC and IC, and email address to me. I've given you my handphone number, and then we will do it manually. Okay. Chua, sorry, you were a bit
lagging.
Yeah, your Wi-Fi had been laggy a bit throughout. Okay.
I would suggest that you can consider taking a histamine blocker, something like famotidine, as an alternative to a PPI, though it may not work as well as the PPI. Now, if you still cannot get any relief in it and you need to be on PPI long term, it is still safe as long as you're on regular follow-up, your renal function is monitored, and your diabetic function is monitored, basically.
Okay. Hu Ming Ching asked, I don't refer patients until I try second line H. pylori treatment and it fails. Is it okay or should I refer when my first line? Yes, refer. Of course, Dr. Chua will say refer.
No, it really depends on, how comfortable you are managing it. But I'm not sure what your normal practice is, but normally for second line, I would straight, because there's really no downside to using it.
Okay. I take one more question from Laili Hassan from Facebook first. Do you use H2RA since ranitidine was taken out from government formulary? And is there an alternative H2RA other than ranitidine and cimetidine?
I tend to use famotidine because it's got less gynecomastia than cimetidine, basically. So that's the other alternative.
So do people still use it on a regular basis?
H2 blockers, yes.
H2 blockers?
And there is that issue with the ranitidine. The study in which they showed that it was carcinogenic is actually flawed. So it's actually been withdrawn.
I see, okay. Dr. C.H. Ng asked, many asymptomatic people get their blood tested. Often serology for H. pylori is included. H. pylori prevalence is high in our community. Such practice leads to many being given eradication treatment for. Please share your view on this practice.
Yeah, I see your concerns here, but the problem with H. pylori it is carcinogenic. I mean, it's a class 1 carcinogen. There is an increased risk in gastric cancers. And what would sway me towards definitely treating and not treating is a few things. I mean, if I do a H. pylori serology and the patient's in the 80s, and they're asymptomatic and there's no family history of any cancer and nothing else going on, I may not treat the patient electively. But I would tend to treat the younger the patients are, if they are symptomatic or if there is a family history of any cancer. And sometimes, you know, if you do this screening and then they need to go for something like angiogram invasive procedure, I would definitely treat, because what happens is when they're put onto things like antiplatelets, the risk of bleeding is actually 4 or 5-fold.
I see. And how prevalent is H. pylori in the community?
Now, our studies show it's about 2 to 3%.
Okay.
In Malaysia, and depending on the overall, but it depends on your ethnicity, you see. It is a lot higher in Chinese.
Mm-hmm.
It is a lot lower in the Malays, and in Indians is intermediate.
Now, can I ask, there are more and more questions. Yeah. So Kalavani asked, what's the recommendation for probiotic intake?
Wait, there is no recommendation. It depends on the manufacturer's recommendations because it's just too diverse.
I see. And Shaza asked, may I know which PPI is not advisable for diabetic patients? Are they contraindicated?
No, definitely not. PPIs are not contraindicated in diabetic patients. They are not even contraindicated in patients with renal failure or end-stage renal failure.
Mm-hmm.
But what happens is that people have a concern because there's some studies that show that there is an increase in dialysis or renal failure. And we know that patients with diabetes can progress to renal failure.
So basically,
it's not
concern. Mm-hmm. Yeah. So it's just back to trying to, you know,
balance the risks and benefits.
Yes, and again, trying to explain to the patients, you know, and reduce their doubts. A lot of time is our relationship with the patients that can actually reduce that doubt.
Yeah, precisely. I mean, you have to spend some time explaining.
Yeah, because sometimes they go all this WhatsApp group and Telegram group, all sorts of things get disseminated there, and there are a lot of fake news there. So, can I ask one thing? IBS, do they get upper GI symptoms?
There is a lot of overlap between IBS and what we call functional dyspepsia. No, I won't say a lot. There is some overlap. Yes, you can get upper GI symptoms concurrent with your IBS.
Okay, I'd like to introduce you this slide that Amy did for me. I think it's very beautiful. You can scan and like my page, which is Beating Hearts, and also join us on our medical forum, which we discuss things on a regular basis. And if there is no more questions, I think we will end here. It's been exactly an hour. It's a very good talk. I really enjoy it. Very simple, very easy to understand, and yet a lot of information in it. We will invite you back for another talk, hopefully.
Thanks, Betty.
Yes,
All right, good
had
night.
a lot of fun. Bye, guys.
Bye.
Stay safe. We have a lot of cases and we have a lot of deaths. So see you next week. Next week is also another CPD point talk, also with Sunway, and I think Alex Tan is coming to talk about thyroid disorders. Okay, have a nice evening and
Thank
wait
you.
for it. Bye. Thanks, Chua.
Thanks.